Thank you so much, Francis, and thanks to the organisers for the opportunity to be here. It's really lovely to be here, and just wonderful to have sort of this kind of small face-to-face scientific meeting after so many years of disruptions. I just want to draw attention to my title, which I did agree to, but Health System Innovations. So Health System Innovations for virtual HIV elimination and beyond. And I'll just quickly go back to what those targets actually are. So we've heard a bit of this from the previous speakers. But this was the UNAIDS 2014 Fast Track Strategy, a very successful example of what Jakaya was complaining about, one of those strategies where you're promising the Earth in remarkably little time. And it was aiming to end AIDS as a public health threat by 2030, endorsed in 2016 by the UN General Assembly, and re-endorsed in 2021 with more ambitious prevention goals. The major sort of bedrock of it still is the treatment as prevention. So that was the 1990 targets, re-endorsed as 95 targets. So diagnose 90%, I'll do the 2021s. Diagnose 90% of people living with HIV, start 90% of those on treatment, attain viral suppression of 90% of those. So 90, and now 95. And that was modelled as having a major impact on new transmission, so new HIV infections. And it derives from the science showing that once you get people virally suppressed, essentially they really don't transmit to other people. So even with unprotected sex, you name it. So the so-called undetectable is uninfectious, U equals U. And that's become sort of the basis of law. So you're not criminalised for having unprotected sex and not disclosing your HIV status in many parts of the world, as long as you're on effective treatment. And however, the knowledge of HIV, just knowing you're positive, does result in quite pronounced behaviour change as well. So it's those two factors acting together that give you the HIV prevention benefits. Other than that component, which of course also has like the very important humanitarian benefits, and also the benefit of not having a lot of people around the globe with immunosuppression, which has many other benefits for the population as a whole. There is this combined HIV prevention interventions that we've heard about, and then addressing structural barriers, stigma, discrimination, and criminalisation. So that's the whole sort of package that was re-endorsed in 2021. And just to say, it is quite fragile. So it has been remarkably successful, but we've got no vaccine or cure at the moment. Viral rebound dynamics are such that if you stop treatment within 2 to 4 weeks, your viral load can be back up to where it was before you went on treatment. So it was as if you never had treatment before. And at the moment, the program's success largely rests on a single drug, dolutegravir, that has a high threshold for drug resistance. And we know from various viral genome typing studies, notably the Pangaea Consortium, that there's widespread resistance to the other antiretroviral drugs in Africa, and a growing burden of dolutegravir resistance as well. But dolutegravir is pretty robust. And I was in Malawi when that was introduced in 2019. It was introduced as a sweep across the country. That's one of the great things about Malawi. The public health programs are really great to work with, really organised, low cost. So the whole country moved over to dolutegravir in 6 months. And all of a sudden, you just did not see advanced HIV coming into the hospitals at all. The whole sort of face of what you were seeing in the hospital just changed completely. And we did 2 studies in the same hospital, Zomba Hospital, one in 2016 and one in 2020, dramatically different. And that progress has been remarkably good. And as far as my bit is the diagnostic intervention bit, really. So as far as the treatment side, this is just showing that first 95, the testing bit. That's still where the largest gap is. So once people know they're infected, they generally take action at some point. It's a fraction of the expenditure compared to HIV care, and it's still the biggest gap. And notably, I'll show on the next slide, but we have less good coverage for young people, for men, and we know that, and as Loveleen showed, most transmissions are from people who are not aware of their HIV status, despite in 2020 globally having got to 84% of people who know their HIV status. Okay, there's about 150 million HIV tests a year, and the new strategies include the scaling up of HIV self-testing, as well as partner notification of the type that Augie talked about, peers, particularly among men, and high-risk networks. So those are really what we've got to play with. So this is data from the analysis of various population-based surveys in Africa that have led up to the 2020 sort of declarations of where we are. So it's pretty data-based. Big investment by Bill and Melinda Gates Foundation in the surveillance as well as in the modelling. And by the US government. So those, I would say, are the sort of 2 big funders of this. You'll see Southern Africa doing better than the other parts of Africa. So this is just Africa. But Southern Africa doing better than the other parts. That's where there's been the most investment, but also the most severe epidemic. And so you'd expect people to be taking that seriously. I can see why I was told not to use the pointer now. For men, so substantially less good coverage than for women. Again, what we also know is that this is the group, it's that undiagnosed men between 25 and 40. Sorry, I can't quite see my own slides. 25 and 40. Yeah, it's that group that is doing the majority of the onward transmission. And really quite a lot worse coverage in young people. Obviously, these are relatively recent infections, but just again, the treatment access issues we've heard from Euphemia, moralising, etc., etc. Those are very real problems. But these are the data. So the number of people living with HIV is still growing. That's because the number of deaths is below the number of new infections. So that is basically governs whether the epidemic's growing or not. Currently 31 million people on antiretroviral therapy. So, if we stopped treatment for all of them tomorrow, that's 31 million people having a rebound in 2 to 4 weeks. Deaths down a fraction of where they were, but still off the 2030 targets. And then this is the new infection data. So just under half, so this year for the first time, just under half of new infections were in sub-Saharan Africa. And of course that's great for the region. Malawi is down at only 13,000 new infections, down from a peak of something like, I think it's had an 88% reduction in new infections from this treatment scale-up program. But the rest of Africa, and again, coming from the TB world, Africa's really has got relatively simple health systems that do actually deliver the sort of basics reasonably well. when you compare it to the rest of the world. Once you're into places in Eastern Europe and Central Asia, some of the large countries in Southern Asia, where health systems are really quite complex, quite chaotic, private practice really dominates. There's a lot of doctors offering a lot of cheap services, very little evidence-based practice. So TB control in Africa has been a much more simple ask than TB control in the rest of the world. So I think, this really is something to really worry about. How are we going to start delivering to the rest of the world as well as we have done in sub-Saharan Africa? Again, Asia and the Pacific, Latin America, all growing epidemics. And I think many of the other speakers have touched on this issue, on this topic, really. When you look at the future, wow, it's kind of terrifying, isn't it? We had, and I think this is, if you like, best formulated by the 2023 World Economic Forum report, defining we live in the age of polycrisis. So where any one of, climate crisis, geopolitical tensions, social fragmentation, economic crisis, any of those can have a domino effect on everything else. And just to sort of make it even spookier, we've got this weird cover that looks as if a certain billionaire has decided to fry planet Earth, as if we're a video game, So in that context, we got to. I think, to me, the lesson is get on with it. Let's get that vaccine. Let's get that cure. Let's get the lasting interventions that don't require ongoing cooperation. I really do feel that we should be sort of acting with the same kind of urgency now that we had for COVID. So this is, if you remember, my talk is health system innovations, and I would just say, there are really a lot of really impressive innovations, and I think we heard that from Janet. I mean, innovation is just everywhere at the moment. Again, slightly scary to some extent, but with that opportunity to bring good. So I'll touch on service delivery, workforce, digital tech, financing, and how we maintain quality and coverage at the same time, and that's really the trick of all this interventions. You've got to be affordable, and you've got to make a difference and keep the quality. And first of all, we've heard from Euphemia about self-care, but it really is an innovations juggernaut. This is just a very simple example of the kind of spectrum now that is available for something quite simple that applies to any infectious disease, which is contact tracing. So at one end, you can have a traditional provider led approach. At the other end, you can have a really fully, minimally supported self-care option. And really what we know is that if you don't provide home-based options now, you're not going to get the coverage that you want. So people want choice, people expect choice. If you're not providing that choice, someone else is. And there's a mass of both health system instigated and supported interventions, which are, evidence-based, relatively good products, relatively well supported, and then a whole slew of alternatives that are more or less evidence-based. And you can think about any topic, any design, whatever components, whether it's digital, in-person, there will be private options. And I think with these commercial, so you've got both the commercial and the not-for-profit developers, and really it's all about the market. It's all about marketing now. It doesn't matter how good your product is, if you're not selling it well enough, it will not be taken up. And we have these two types of ecosystem. I saw this phrase, innovations ecosystem, which is like the sort of benign end of it, well, the not-for-profit end, let's say, which is about value creation. And then you've got the business ecosystem, which is about value capture. You know, they have to make a profit, that's the whole point. And if you're doing something that is, you know, better than them, you're actually their competitor and they will come after you, you know, as well as we've seen. You know, people are coming after the World Health Organization. People are coming after the institutes that we think they should trust if that conflicts with their products. So you've got these two competing visions, a 6.3 trillion wellness industry on the one hand, and the WHO's self-care, which is considered essential to meeting the Sustainable Development Goals and universal health coverage, with self-awareness, self-testing, self-management. We've heard from Euphemia, but those are the two very distinct, if you like, competing vision. There definitely is overlap, and I think we can't deliver without the innovation of private companies. But I don't think that we should be, thinking that everything is benign. So one area that I do think is really exciting for anyone who works in communities, so we've heard about a variety of community approaches and interventions. This is something that Rosanna Peeling is very keen on. Social, and if Rosanna Peeling, for those that know her, was director of TDR at WHO and in London School. If anything excites Rosanna Peeling, it's worth really paying attention to. So just some examples that we've heard. I won't go over it because we've heard from Augustin, his suite of interventions, including most recently an NHR Advanced Fellowship that he's got an interview for in January, and that is based on the PrEP. So that's the 6-monthly injectable with showing 0 infections in the lenacapavir arm. So very exciting PrEP. Euphemia, you've just heard from, I won't go over hers, but also very much moving in this same direction. So combining the testing with the management of a broader suite of conditions that people themselves have told you they want. In VITS, again, I won't show a slide, but really wonderful work from VITS Uni and ODEA. So that's also Gates funded, but low-cost, comprehensive digital health solutions with AI support that really just takes you through the whole journey and supports people from their home throughout the whole decision-making, whether it's a test or not, what to do afterwards. The test is supported with an AI read that can identify what kit you're using, help you do the test, and do some reporting, anonymized reporting to the system as well. Linking in with prescription at pharmacies, etc., etc. So really well thought through, comprehensive services. And I will talk just quickly about Joe Tucker and Rosanna Peeling's work in China. This is called Pay It Forward, a social and financial innovation in China. And that came through the TDR has a hub in China. And this basically use crowdsourcing, which is kind of a digital version of what we would think of as community-led. So it's fully digitalized. Again, it has its own sort of format and methods to do it in 3 stages. Looking for ideas, having a winner, and then consensus building. And it seeks to. So they were asked to give solutions for increasing preventive service uptake, which was either a vaccine or STI, HIV testing, in a system where it's a fee-for-service, aviation system. And that uses pay-it-forward approach and pay what you want, which outperforms standard of care. in a randomised trial. And again, there's sort of methods to replicate this, but not only did you get greater uptake, but you also had partial cost recovery. So I think really important. I'm just going to very quickly use a couple of minutes to talk about community-led HIV self-testing in Malawi. So this was one of the last projects we did in 2019. And I don't think it's got the sort of coverage to this audience it would otherwise have had, what with all of the moves and disruptions. But this is a one-week campaign modelled on mass drug administration and the malaria bed net distribution. And what you're looking with community-led interventions, and so with this new crowdsourcing variant, this did not use crowdsourcing, but you're looking for better outcomes for similar or lower costs, and that's really the sort of guide. And this was an intervention in, we randomised 30 different villages, and 15 were supported to provide community-led distribution of HIV self-testing, which literally you're just doing a kind of a commodity drop and leaving it to communities themselves to identify, to do the distribution, the mobilisation, get people linked into care and prevention. I'll skip through, but basically these are the sort of top line figures. So in 1 week, 24,347 kits distributed, and it was at the lowest cost of any of our HIV self-testing interventions, $5.70, and that compared to $4.57 for routine HIV testing in nearby clinics, so very comparable. And we found 74.4% of survey participants had used a self-test kit. Our primary outcome was coverage in adolescents, and we saw significantly increased despite being in 2019, so right coming up against the 2020, all the efforts to reach the 2020 guidelines. But we did not see an impact on treatment as prevention, and we're seeing that with Augu's work and also with work in ARI in South Africa. Basically, it's too much information all at once, and people are really focused on that self-test and not having that much time to adapt the rest in. What I would like to see is to see that moving into a kind of campaign approach. This was a model developed with Andrew Phillips' groups, but it was binned as being not ambitious enough, but I think it's pretty cool. It would be doing a 5-year self-testing intervention to maintain, to mop up undiagnosed needs, get the country back up, and you could see how this could integrate really well with digital interventions. You could get the costs down, people could be more engaged, and they'd have like a longer time, if you like, with their AI digital assistant to get the HIV prevention concepts across fully. So that's sort of what I'd love. In the last couple of minutes, I'll just quickly touch on economics, because that is the bottom line, unfortunately. So for STAR, we had this very successful scale-up between 2015 and 2024, from negligible tests in 2015 to 4.8 million tests distributed by the STAR program itself, cutting through all the market entry regulatory barriers so that we now have a sustainable current market of 36 million tests in 108 countries. In that 3 phases, with the first phase, 650,000 test kits distributed all under research protocol. So that was STAR. I mean, that worked because it was a great test. It cost $2. It's genuinely point of care. It's the oral test kit. Sorry, I meant to say that earlier. An oral test kit, and you get a yes/no answer. It's none of this nuance that we have with COVID or with the sort of semi-effective TB tests where you're saying, we think you don't have it, but if you still have symptoms, go and get a test somewhere else. It's a really clear answer. So that's the special thing about HIV. Even then, I was expecting it to be cost-saving, but basically you don't get cost saving unless it's like a vaccine where you have a lasting change in immunity, or like a VMMC where you have a lasting effect that remains with that person for the rest of their lifetime. What instead we found is it was cost effective. So provided there's willingness to pay, it was within the threshold that you would expect donors to be interested in funding. And this slide was Hendy Maheswaran's slide in this was the slide that really got the Gates to say, okay, we're doing the buy down. I mean, they were, it was the last little push that they needed. Since then, we've done costing at scale in South Africa. So this was moving from 1 million self-tests a year to 6.7 million self-tests a year, and they want to know how to distribute it, etc. This is using the Tembisa study, mathematical modelling study, and basically this just shows this is the sort of quadrant you're interested in. That means yes, it's cost saving, and really you had the workplace distribution in with a shout. Sorry, that's Augustine's type secondary distribution, more expensive. You can't scale it up because there's a limited number of people that you're doing secondary distribution with. This is the sort of fast and furious type distribution where you're not quite sure what your linkage is going to be. And then down here, they estimate was actually worse outcomes with primary care facilities, so less good linkage, despite the fact that it's lower cost. So again, you really do, if you want policymakers to take you seriously, you do have to have the costing. Just quickly then, in conclusion, so yeah, I mean, we definitely live in exciting times. I think that's sort of, I mean by that, one worse than we live in interesting times. But nonetheless, there are reasons to be hopeful. I think health system innovations can, for HIV, get us close to key 2030 elimination guidelines. The treatment and target are the most, testing and treatment targets are the most attainable. But we're now moving into the rest of the world scenario, which we know is a lot more complex. I do think digital innovations can drive that. But the standard approaches we know are going to struggle. For prevention, lenacapavir offers real promise for scale-up. For all the investment, we need concerted innovations, and particularly for regions with growing HIV epidemics, and we do need global cooperation to prevail. As soon as possible, let's have a breakthrough in cure, therapeutics or preventive HIV vaccination. The digital innovations are going to enable much more effective self-care. We should be getting behind those and supporting, how to do it well, because we're up against those who really don't care whether you spend your money on something that's toxic or effective. And crowdsourcing is a way that can allow us to do that. I think maintaining affordability and keeping an eye on value for money is just essential anyway. Has to be appropriate for the setting that you're in. That's my acknowledgement. So thank you very much to the organisers, to Liverpool for being such a wonderful host to me for all my years in MLW, Unitaid, Welcome Trust for funding, and those folks listed down below. Thank you.